This is lower gastrointestinal bleeding tutorial presented by the SchrDbb with reference, a practical guide to issue taking and clinical examination by Anwar Qais Saadoon. Hello, we are going to see lower gastrointestinal bleeding. So lower gastrointestinal bleeding, lower gastrointestinal tract bleeding is a bleeding from gastrointestinal tract distal to ligament of trace. So proximal to ligament of trace, upper gastrointestinal bleeding. Distal to ligament of trace is lower gastrointestinal bleeding. Hematochezia can be defined as the passage of light red or maroon colored blood paired is just the same as rectal bleeding. So it is usually indicate lower gastrointestinal bleeding or relatively occur to massive bleeding distal to ligament. Now we have Coran jelly stones, Coran jelly stone or gelatinous stones composed of a mix of small mucosal mucus, usually indicating dissection. We have what is called the Coran jelly stone. It is a gelatinous stone. It is a mix of mucosal blood and mucus. We have gelatinous stone linked to mucosal blood and mucus take off intussusception. It's the physical and clinical condition. The next thing is identification of the identity is the issue taking of lower gastrointestinal bleeding. That identification of chief problem. We have the issue where we have the tuition, we have the stool characteristic and the bright, the dark melanoma, Coran jelly, and the fecal mucus. So we have the location of the blood in relation to the stools. We have quantity and severity of bleeding, consistency, and any change in bowel habit, caliber, shaded symptoms. If you are shaded with abdominal pain, you can think of a colitis and inflammation bowel disease or insusception. If you are shaded with constipation and rectal pain, you think of anal fissure. If you are shaded with anal lesion, vomiting, all that. So the case you have to know. Passage, you also know the maternal drug use, warfarin, anticonvulsant, and isoniazid that can predispose the patient to bleed. We have mode of delivery can, in case of the stress ulcer, we have low birth weight, we have prematurity in case of necrotizing enterocolitis, when neonatal jaundice, we have vitamin K prophylaxis. Now, past medical and surgical history, some attack of in the past, inflammatory bowel disease, we have constipation and rectal condition, peptic ulcer in the past, we have hepatitis, we have jaundice and all that. So now we have medication issue, anticoagulants, we have aspirins, pneumonia, NSAIDs, steroids, all that can predispose to bleeding. Family issue, you have to know family issue of liver disease, peptic ulcer disease, bleeding disorder like von Willebrand disease or hemophilia. Social issue, we have issue of travel, sexual abuse. Review of system, we have disturbed level of consciousness, cerebral simple palpitation and sleep. Now, key points: a sudden onset of severe episodic abdominal pain, especially with vomiting, passage of red Coran jelly stones, is in the first 2 years of life should raise concern of intussusception, which is frequently preceded by upper respiratory tract infection intussusception. That's the first thing. The second, the most common cause of bleeding perirectum in children is an acute anal fissure. That's the most common cause of bleeding perirectum in children, acute anal fissure. Streak of bright red or bleeding on the outside of the stools may suggest a diagnosis of anal fissure. Streak, if you have to look at the streak of bright red blood on the outside of stools, may suggest a diagnosis of anal fissure, particularly if associated with passage of hard, painful stools. In young child, the recurrent passage of small amount of blood in stools without pain may suggest juvenile polyps. So if you have a recurrent passage of small amount of blood in stools without pain, may suggest a juvenile polyps, especially when there is no issue of constipation. The occurrence of bleeding per rectum in conjunction with diarrhea, abdominal pain should make you think of an infectious colitis. So any infectious colitis can result to bleeding with pain. If you have bleeding per abdominal pain, you have to think of an infectious colitis. But usually, if you have bleeding without pain, you have anal pain, you think of anal fissure. Bleeding without pain, think of a juvenile polyp. And if you have a recurrent jelly bleeding, you think of intussusception, which is precipitated by a upper respiratory tract infection. Or if you still have pain with bleeding per rectum or hematochezia, you think of inflammatory bowel disease. When bleeding per rectum in absence of diarrhea or pain may suggest proctitis, or you can still think of proctitis. And proctitis is very common in patients that are having an anal sex, and that proctitis is going to be due to a Neisseria gonorrhea or chlamydia. So we have rectal bleeding in ulcerative colitis is usually profuse with tenesmus and hypogastric pain. You also have pain here. Children with Crohn's disease may present with right iliac fossa pain, weight loss, failure to thrive. So you have Crohn's disease, you have right iliac fossa pain, and that pain is relieved when you are defecating with Crohn's disease. Crohn's disease is a right iliac fossa pain, while ulcerative colitis is mostly a hypogastric pain. So the next one, and you also have failure to thrive. We said that you also have arthralgia, and you have anal fissures, and you have anal fissures. So we have early childhood. If you in early childhood, that's less than 7 years, acute onset of colicky abdominal pain, polyarthritis, hematuria, purpura, vomiting, rectal bleeding suggests the possibility of a Hinoch-Schönlein purpura, especially preceded by a viral illness. The Hinoch-Schönlein purpura can either be due to a viral infection, or it can be due to a Neisseria meningitis infections. So, and it's presenting with, we have polyarthritis. Hinoch-Schönlein purpura, you need to know that it's among the vasculitis disorder. So that's why he has polyarthritis, has hematuria, he has it's among a connective tissue disease, and among those connective tissue diseases, among vasculitis. So you have hematuria purpura, vomiting, hematuria purpura and polyarthritis associated with abdominal pain, vomiting, and rectal bleeding. So that's Hinoch-Schönlein purpura. So we are finished with lower gastrointestinal bleeding. We now continue with jaundice. Thank you for your kind attention.